Perfect segue. We originally submitted to the FDA for a PMA approval for prostate cancer. We were not successful with that, but working with the FDA proactively on their part and our part, we were able to obtain a tool claim for our technology. And part of, as Dr. Viviano mentioned, part of the special controls that were part of our de novo regulatory authorization was to submit a training program to the FDA that they would approve as part of our submission, and that then we would apply in the field. One differentiation that we make, we do have a training program, we do not have a credentialing program. We have a certification program. So we certify that the users are skilled and able to use the equipment. We believe that credentialing is something that is in the province of the hospital to determine whether the individual user has the credentials necessary to use the technology in the hospital. We have a training program, as mentioned, a post-training support program, medical staff training, which we've added as well, and office staff and HIFU program development. I'm not going to go through all the details of this in the interest of time, but basically we have a 4-stage process. There's online training, there's one-on-one interactive simulation training, there's live case observation training, and then we get to the point where the patient's actually using the equipment in their institution. We provide a certain number of clinical visits to get them to the point where we believe a normal user should be able to use the technology. If at that point we do not feel that they have demonstrated competence, then we will increase the number of cases where they require supervision. In addition, we provide something that we think is unique and potentially of value in an extended range. We provide something that we call SonaLink. So each of our systems is equipped with the ability for the user to say, I want remote support. And we dial into the case, we see the exact screen that they're seeing, we see the patient in the room, we see the physician, and we can interact with the physician remotely in order to help guide them through the case. We provide this for as many cases as they want, for as long as they want. It's a quality control measure. It's a way of helping them to get comfortable. We can dial a remote physician in to help that individual if they feel that that's the best way to proceed. We also, as I mentioned, have faculty staff training and certification. There are a lot of requirements in our regulatory submission in terms of how the equipment is post-processed after use and before the next use. That requires significant facility training and staff training, as well as the office staff. How do they bill properly? How do they manage patient documents? What kind of data should be collected? How can they integrate into the registry? And I will identify that one of the differences because of this training program and our special control with the FDA, we are not allowed to run the equipment. We are not allowed, the physician is not allowed to be sitting in the room while somebody else is running the equipment. Remember that the special control stated that the physician shows competency in using the controls to deliver the ablative energy and to spare sensitive structures, which means unlike certain lithotripsy models where the physician's in the room but there's a technician running the whole show, or in radiation therapy, essentially that's not possible with this technology. And I will emphasize the idea of a multidisciplinary team. This is just something back from the early days of radiosurgery and stereotactic radiation therapy. Multiple integrated teams in terms of credentialing and getting involved in determining what the training should be and what the criteria should be for certification. Thank you.